Sir, who is a remarkable radiologist from Madurai. He is currently the Managing Director and Chief Consultant Radiologist of KGS Advanced CT and MRI Scan Center, Madurai. He has done his MBBS from Madurai Medical College and received medal in Medicine, Pathology, Psychiatry and Pediatrics. He has done his MDRD from Nagpur University and emerged as University First. He has received 3 awards including Best Doctor Award and Best Radiologist Award. He has 13 published articles, 4 published book chapters. He has attended more than 63 CMEs and presentations. He has won multiple prize paper awards, won multiple quiz sets. He is a continuous winner of Radiology Education Foundation Quiz Mumbai, author of multiple publications in IRIA and IGNR journals. His special interests include orbital imaging and neuroradiology. Over to you, sir.
I wish to express my sincere thanks to Dr. Devi Meenal to give me this opportunity. I divided into 3 topics. One is patella, other one is TM joint, other one is ankle. From very basics to some of the advanced applications. The consultants may look, it may be very simple, but it will be very much useful to the radiographer as well as postgraduates. In beginning period, how to measure some of the things like patella tracking. Whenever the consultant asking for patella, few of the things the orthoscopic surgeon will expect from us. And what are the things they are expecting from us, I will try to learn. First, try to put the localizer. Localizer should be sagittal, axial and coronal. Then planning of axial, it should be 3 mm only. It should be less than 3 mm, PDFS or without fat sat. The cut should start above the patella and we should include the tibial tubercle because this is the area the extensor apparatus is very important. And what we will get is the axial images, it will be like this. Then the coronal images. Coronal images, we can see the first cut is starting in front of patella. The last cut will go behind the soft tissue compartment because it should include the popliteal vessels also. And the next slice will be sagittal. All slices should be less than 3 mm. The sagittal, it should go along the parallel direction or it should be like this planned, or we should see the ACL. Always see the ACL and plan it along the course of ACL, which will give more benefits. We can able to see the Bullman-Stat, along the Bullman-Stat line, the ACL will be seen properly, and this is very much essential when we are going to plan sagittal slices. Let's start with extensor apparatus. What is this extensor apparatus? It begins superiorly at anterior inferior iliac spine and extends distally. What are the structures forming the extensor mechanism? It is quadriceps muscle group, quadriceps tendon, and our hero patella, patellar tendon, and the insertion of patellar tendon on the tibial tubercle. What is the main purpose of extensor apparatus? It is very much essential for maintain the erect position, especially standing, or when we are coming up from stairs or climbing up or down. It is acting like a fulcrum. And this is very much because it is to elevate the patellar as well as extensor tendon. So patella is very, very essential organ in our body. And what are the pathologies can occur? It is Osgood-Schlett's disease or traction apophysitis of the tibial tubercle or tibial tubercle avulsion fractures and upper portion of the patellar tendon, so-called Jumporsny, Sidding-Larsen's-Jaggesen's disease. Patellar sleeve fractures, recurrent patellar dislocation, relocation syndrome. This is called as patellofemoral instability syndrome. And sometimes the patella may be congenitally hypoplastic, and how to evaluate all these conditions. And muscle injuries, especially quadriceps tendon, can get avulsed from anterior inferior iliac spine, or muscle strain can occur in muscular group, it can occur. Let's start with anatomy. What you are seeing is the quadriceps tendon. You can see this is full course of quadriceps tendon. It is a quadriceps tendon, vastus intermedius and vastus lateralis and vastus medius together. Then this is full course of patella, and what we are seeing is the patellar tendon insertion over the tibial tubercle. This is one. So all this together we have to carefully look. One important point I want to emphasize. Patella alta simply by seeing the trochlear cartilage. You can see the trochlear cartilage here, and you can see the patellar articular surface. At least 1/3 of patella should articulate with trochlea. If it is not there, if it is going above, confidently you can say it is patella alta. If it is coming down, means it is patella baja. The simple rule, it is not the insult-solvent ratio, other ratios, everything. This is 1/3 of your patella should articulate with the trochlear cartilage. This is a simple rule in SAG. You can work it out whether it is patella alta or not. And starting with osgood celators, we should know about the physis plate of tibial tubercle. It is originating or it is developing as an anterior extension of a proximal tibial physis plate in early pregnancy. In females, it is closing earlier, 13 to 15 years. In males, it is 15 to 19 years. That's why if you are going to sports injuries, young girls starting their sub-junior, they are more prone to have this osgood celators when they are 13 to 15 years old, less than 15 years old. Male, it will come little bit late after 15 years. And one unique nature of this cartilage is it is composed of fibrocartilage. Rest of the cartilages are columnar cartilages. This is a sagittal PDFS beautifully demonstrating. You can see the traction apophysitis, and you can see the partial strain, fragmentation, marrow-edema, prepatellar and retropatellar soft tissue changes. These are all very classical features of osgood celators disease or traction apophysitis. Complementary CT 3D sections are very much useful because we can assess how much it is displaced, whether the whole portion of this tibial tubercle is involved or portion is involved, or it is involving entire physis plate along with it is taking over the epiphysis. All these things are going to decide the surgical management. That's why the Ogden classification has come, whether it is involving the distal portion or entire portion of the tibial tubercle or it is traversing through the physis plate. All these things are very much essential for reporting aspect as well as for the surgeon what he expects from us. This is classical distal portion. You can see the only distal portion has come out and it has gone for marrow changes and along with the traction apophysitis, all these things. Here entire thing you can see almost it has traveled from here. It has gone out and you can see the traction apophysitis, marrow changes. Here you can see it is not only here, it is involving the physis plate also. So it is a severe form of osgood celators disease. So we have to say which portion of this tibial tubercle is involved. That is very much essential. When we are coming to proximal tendon involvement, this is site where we have to look. You can see the classical involvement of traction apophysitis of the proximal patellar tendon attachment. This is called as a Sitting-Larsen's-Jacobson's syndrome. Patellar tendon can rupture in any place. It may be even partial. You can see only few fibers are gone. And only this particular area there is a hematoma, and which is prepatellar fluid collection is there. And if you are carefully evaluating, you can see the complete rupture of the lower portion. It is ruptured and there is a hematoma anterior as well as posterior to it. It is a total avulsion. You can see almost the extensor injuries you can see here so severe. There is no patellar tendon at all. If you are carefully seeing, ACL is totally gone and PCL is also totally gone, and there are injuries to the avulsion, injuries to the entire. So it is a floating knee, almost dislocated knee joint. So almost entire thing has gone anterior to posterior. So all these things we have to be carefully look into it. Patellar sleeve fractures, when it is going for avulsion of the inferior pole, this is classical avulsion fracture of the inferior pole of patella, or chatted patella like this, multiple fractures. And you can see sometimes the patella can fragmented into two pieces. One piece is left over here, another piece is left. This is commonly seen with when the MPFL is not able to rupture, it will totally avulse the entire portion of the patella facet and it will come and stay here. This is very much important because the surgical plan is different. And plica syndrome can occur. Plica, suprapatellar plica, infrapatellar plica, lateral or medial. This is classical example where we have to look the suprapatellar plica. It is thickened and inflamed and effusion is there. Synovial neoplasms can occur. Suppose if it is post-arthroscopy, it will be of cyclops lesion. If it is non-arthroscopic patient, if we are seeing any soft sumas, by seeing the calcification, we can see it is synovial neoplasms. If we are not seeing, it may even a cause of pigmented villonodular synovitis. All these things we should carefully look when we are evaluating for extensor apparatus. Bipartite patella may be a normal variant. We should not misunderstand, because the ossification center is not fused, which will mimic like some form of patellar fracture or something else, which we should not misunderstand. The cartilage, one thing, the cartilage will be seen nicely. This is the one beauty. That is the one thing we have to look into it. Coming to our main topic, patellofemoral instability. What is patellofemoral instability? For that, few requisites are there. We have to know the normal anatomy of patellofemoral joint. What are the risk factors for patellofemoral instability, and how to evaluate and how to measure them. And we have to review the pathological findings, and what are the things we have to look. There are 8 main findings. It is very much important. Whenever it is dislocated and relocated, so kissing osteochondral injuries in infromedial patellar facet, lateral femoral condyle. Whenever it is injured means there will be a loose body formation. There will be a tendon rupture, so MPFL, medial patellofemoral ligament disruption. And why this is happening, there should be some underlying pathology like trochlear dysplasia, or the angle is very shallow, that is called as sulcal angle shallowing. And patella may not be of normal size. It may be of abnormal size or hypoplastic, or almost one patellar facet may be absent. Or patella may be high riding, that is called as patella alta. Other findings like marked knee effusion and internal derangement can occur. And how to see this step by step? It is osteochondral injuries, kissing, contusion and loose body. So you can see it has gone and hit. And you can see the medial, infromedial patellar facet, there is a osteochondral injury. So it has hit over the lateral femoral condyle, you can see over here. So kissing contusions, it is kissing contusions in those 2 main areas. And whenever it is kissing contusions, always you can see here, this is another patient, you can see the medial patellar facet and you can see the lateral femoral condyle injury. And you can see the coronal images, you can see the patella, this is the infromedial patellar facet, it is injured, and if you are seeing femoral, it is the lateral femoral condyle. So these are the sites where we have to carefully look. The osteochondral injury. Whenever osteochondral injury, the impact will be there. So you can see the fragment from here, it has gone and denuded, there is a loose body here. Because whenever they are doing arthroscopic surgery, they can get and they can go for same autologous reimplant. That is very important. That is there. For that purpose, we have to be very careful. Where is that loose body? And coming to MPFL injuries. MPFL injury is very much essential and very much useful, and we have to report where it is injured. It is medial patellofemoral ligament. Normally it will be like this. MPFL is medial patellofemoral ligament. We have to mention whether it is full thickness along the patellar attachment site, or mid substance, or it is along the femoral attachment site, or entire thing has gone. These are the things we should report in our thing, because whenever we will seeing this medial patellar facet injury, we should always look carefully what is happening over the adjacent MPFL. That is very much essential. You can see the MPFL injury, particularly we can see it is on this side, and this is absolutely normal along the central as well as femoral attachment site. You can see almost full thickness, near complete full thickness tear has come, almost it is along close to here. And you can see the central portion is injured over here. So which portion it is, anterior third or middle third or femoral attachment site? You can see the femoral attachment site is freely floating. Apart from, you can see the patellar attachment site also. And here you can see the patellar attachment site is absolutely normal. And you can see the this is femoral attachment site has gone. So the crystal clear mention of where this MPFL is injured, it is full thickness or partial thickness. All these things are very much essential. And how to look for dysplasia of the patella, trochlear groove, patella alta measurements, and the lateralization of tibial tubercle, so-called how to calculate the TTTG distance. If you are saying patella, it is having 7 to 9 facets. But for us, only 2 things are very important. Is it medial facet or lateral facet? They are divided by one ridge called median ridge or patellar eminence. Lateral patellar facet is longer and more sloped to match the lateral femoral condyle because it has to go freely and it has to lodge in that particular place. And lateral patellar facet is 1 centimeter higher than the medial patellar facet. That is very much essential. If you are seeing the patella itself, you can say confidently whether it is normal or not, because it should have at least the ratio of lateral to medial will be 60 to 40. It is not 50-50, it is usually 60 to 40. If it is going 30, that means it is type. It is less than 25 means it is type 3. It is Weber classification. But now there is one more fourth type that is called as Jaggergut patella, where there is only one articular surface. If you are seeing carefully, there are two articular surfaces. You can see, but if you are coming, it will be less. It will become more or less. But if you are seeing Jaggergut, you can see only one facet will be there. There will not be second facet. There will be one articulating facet that is called as Jaggergut patella. That also quite common. We have to be careful. That will be very severe form of patellofemoral instability. This is type 1. You can see the articular surface which will be of almost, you can see nicely, it is type 1. And you can see that here it is medial facet is very small. You can see the lateral facet almost it is becoming 25 to 75 ratio. And you can see still less. You can see the medial patellar facet is very small. Lateral is becoming more. Here there is only one articular surface. There is no second articular surface. So these are the things carefully we have to look when we are evaluating for patella. And the patella alta, which I told clearly, you should have. This is normal. You can see the articular cartilage and you can see the trochlear cartilage, and it should be 1/3 will be there. And here you can see how much it is above. And other way of measurement is, see this is, you can see the TL by PL measure. It is the tendon length and patellar length. Measuring this, we can say confident this is the tendon length by TL by, what we can say confidently what is happening TL by PL, we can say confidently what is going to. If it is more than 1.2, that is a radiographic demonstration. If we are going for MRI, it is 1.4 to 1.5. That is very important because MRI you are seeing directly the tendon, and measurement should be taken from the inner surface. It is not the outer surface. It is inner surface of the patellar tendon. That is very much essential. And upper pole to lower pole correctly we have to call, because we can see here what is happening over here. This is the correct way of measurement. Inner surface. It is not the outer surface. And this is the way how we have to calculate patella alta. And coming to trochlear dysplasia. Why this trochlear dysplasia is very much essential? Because it should be sufficiently concave enough to guide the patella throughout the normal range of movement, and the dysplastic patella may be shallower than the normal, even flat, or it may be convex. So for that we should be very careful. We should look for position. You can see how it is looking fairly normal. You can see it is looking almost normal, or it will be little bit shallow, but the shape will be preserved. Then it will become flat. You can see the flat, or you can see it will may, sorry, this is it may become it is flat, or it may become, you can see the convex, or sometimes we may get the clip fatum where we will have this angle. This is very much essential. We have to carefully look. This is normal trochlear. You can see the normal trochlear sulcus, how it is beautifully seen, and it has become flat. You can see it has become flat over here, and this is the mild convexity, and you can see the other case where the cliff is there. It is like a bulge. So all these things, calculations are very much essential. Is it flat, or is it convex, or is it going for clip pattern? This is very much essential. The quadriceps angle or Q angle we can measure. It is angle between vertical axis of the femoral shaft and the vertical axis of the patella. Small angle of 15 degrees expected in normal valgus alignment. And how to calculate? Just I will demonstrate how simply we can do over here. I will demonstrate here, and this is way how we will do it. You can see the sulcal central portion. Usually it will be less than 140, 138 to 142. If it is more than 145, definitely that means the sulcal angle is very much essential. We are going, it is indicative of trochlear dysplasia. And the lateral trochlear inclination angle, this is also another simplified, whether it is flat or convex or all these things to calculate. Just to draw a line, another line you draw over angle over here, immediately it will go, it is what is happening over there. If it is less than 11 means it is considered as abnormal. This is called as lateral trochlear inclination angle, LTIA. Trochlear facet asymmetry, we can see the width, what is happening over the medial patella and what is happening over the lateral trochlea. And it is the ratio of medial to lateral trochlear with less than 0.4 is indicative of trochlear dysplasia. And trochlear depth, how to measure? You can see, draw a line from posterior femoral condyle, from the lateral margin of the medial, from the posterior margin of the lateral, you can see full length, and this is the trochlear depth. If it is less than 3 millimeter, means it is mean value. Calculate this plus this. So A plus C minus B. So A plus C minus B will give what is the depth. So it is very important. If it is less than 3 millimeter, means definitely it is less depth. So to come. And lateral subluxation of patella. It is very simple. You can see that here we can draw one line, distance between the lateral margin of the trochlea to the lateral margin of the patella. If it is more than 6 millimeter, means it is significantly sub. Normally 1 millimeter, 2 millimeter is almost, it is near normal. If it is more than 6, means it is definitely abnormal. So lateral patellar subluxation, how to measure these angles. And TTDG distance, there are 3 to 4 types how to measure. In CT 3D means it is very simplified. You can see how much the tibial tubercle is lateralized. It is very easy. We can see the measurement and how to measure it in MR. See, this is a classical where we will have the trochlear, you can see the trochlear, typical DG, trochlear, and you can see if you are measuring, you would just select series and you can draw a line, it will go down, and if you are doing another one, you can see it will come. So what I have seen, that this is the line which I have drawn over here, and this is the maximum area where you can see the tibial tubercle. So TTDG distance, I will demonstrate real time how the select series we can do. Our last one video is there how we simplify we can. So it will give the distance, how to measure the distance. It will give, if it is 15 millimeter means it is abnormal, 15 to 20 means definitely abnormal, more than 20 millimeter means significant trochlear dysplasia. So after drawing this select series and put a line, go down, and you can see, you can see, and distance between these two things will help always what we are going to do. Then coming to cartilage imaging. What is this cartilage? Cartilage basically going to the anatomy or molecular level. It is a hyaline cartilage. It is made up of chondrocytes surrounded by abundant extracellular matrix. And extracellular matrix is water, collagen, and plenty of glycosaminoglycans and proteoglycans. Our role is what is the status of the cartilage, what is the status of the proteoglycans, what is the status of the glycosaminoglycans. For that, the methods are the T2 star mapping is the one to assess the collagen, and T rho as T gimeric is the one for assess of the proteoglycans, and glycosaminoglycans can be assessed with the GAC chest or gimeric or sodium imaging. These two things are still under working in progress or still under research progress. The first one what we are saying we are doing regularly, and this is one how we will see. First we will do one very good PDFS or medic sequence. Beautifully we can see the cartilage. What you can see the cartilage, there are 5 layers, at least 3 layers you can able to judge. You can see the first, you can see the second, and the last one third, then the cortical bone. And what is happening, how much depth it is going, is it normal or is it signal changes alone, is it defective of 50%, more than 50%, bone marrow changes, all these things we can say chondromalacia patella staging is there. Outer bridge is classified by seeing this, you can see the normal, how, see the cartilage, this is medic, beautifully we can, this is the cortical bone, and you can see the cartilage, and you can see the trochlear cartilage over here, this is the normal cartilage, it is grade 0. Cartilage signal abnormality, you can see this is the normal signal. If you are carefully seeing, there are signal changes over here. You can see the signal changes are there. But appears architecturally it appears normal. It is grade 1. And grade 2 where there are focal defects, you can see the low signal has gone, it is extending, but it is less than 50% cartilage thickness is lost. It is grade 2. And if it is more than that, you can see the more than 50% subtle changes, you can see it is significantly gone, it is grade 4. It is almost no cartilage at all, you can see the no cartilage at all. There are significant changes in the bone, you can see over here. These are all very classical of grade 4 chondromalacia patella. So by seeing this confidently, we can see what is happening over the cartilages. How to do T2 star mapping? This is one what you are seeing. This is first after doing these cartilages, and the T2 star sequence is run over, and T2 star relaxation time will give whether it is plotted as a red color or it is of blue or what is happening over this. And the relaxation time, T2 star relaxation time can be plotted as a curve. We can see the region of interest, which will give, normally it is 20 to 40 milliseconds. If it is exceeding 40 milliseconds means the cartilage. Why this is we are starting? By seeing morphology, our eyes are picking up the defects only. In stage 1, especially stage 2, where we were not able to pick up eyewise by seeing the signals before that, confidently the T2 star will be of higher than the normal. So for that, to early picking up of chondromalacia patella, T2 star imaging has come. By seeing the value of T2 star, we can able to say whether it is normal or abnormal. All these things we can calculate over here. Osteochondritis dissecans means it is a post-traumatic full thickness defect. You can see the trauma acutely disrupting the full thickness or partial thickness of the cartilage. It is called as osteochondritis dissecans. It can come in any cartilage. It's not necessarily patellar cartilage. It can come in trochlear or any ankle, wherever there is cartilage, it can come. And what are the take-home messages of patellar tracking? Always please carefully look quadriceps tendon, carefully look patellar tendon, and what is happening over the insertion side. It is classical case of Osgood Schlatter traction apophysitis. Is it involving the partial thickness or full thickness, or involving the physis plate also, extending above epiphysis is involved or not? And not necessarily the lower portion of patellar tendon get injured. It can injure the upper portion also. If it is in upper portion where inferior pole of patella is also gone, that means it is called as jumper's knee, so-called Sitting-Jagasson's-Larsen's syndrome. And sometimes fractures can occur if the tendon is strong, the bone is weak. It is called a sleeve fracture. And the tendon is weak, where you can see the inferior and patella alta. I told a simple rule, not necessarily solvent ratio. It is 1/3 of patella will articulate with trochlear cartilage. If it is not, means it is going above. It is alta. It is going down, means it is patella baja. And 8 rules which I told. Whenever patellofemoral instability, kissing, contusions, medial, you can see the medial patellar facet, lateral femoral condyle. What is the shape of patella? Is it small, or is it no cartilage at all, no articular surface at all, or it is a ratio of 40-25, less than that, patella shape? Then the trochlea, is it flat, or is it convex, or is it is clamping or cliff pattern? What is happening? Then the assessment of sulcal angle, you can say whether it is more than 145, it is abnormal. Then put a straight line and coming, and you can see assessing the TTG ratio we can assess, and the patella alta calculation. So all these things. So simplified rule, 8 points we have to write in report what is happening, and is what is happened to the other ligaments also. ACL is intact, PCL is intact, posterolateral corner how it is in, posteromedial corner how it is in. So these are the things you should look whenever you are evaluating for patellofemoral instability: patellar depth, lateral trochlear inclination angle, and the lateralization of how the lateral patellar is subluxated, and all these things we have to give it in our reporting. 8 to 9 points we should give it in reporting. This is simplified. One video I demonstrated. You can see there is a injury to the medial patellar facet, and you can see how it is going. I am going to show the lateral femoral condyle. So kissing, contusion of medial patellar facet, lateral femoral condyle. And this is the first step we have to look whenever we are seeing this. Then we are coming down. And I am seeing how the MPFL is totally gone. Full thickness of MPFL injury. You can see that. And you can see that is a loose body. That loose body I have demonstrated how the loose body has denuded, and we have to look that loose body also. You can see there is a loose body along with the synovial cartilage, full thickness it has got. And there is effusion also. And I have selected, wrongly I have selected the line. I should select the angle. So I cancelled it. So you can see what mistake I have done. So I want to delete it. I want to select the angle. How I am doing. You can see that this is simplified way. It will tell immediately what is happening to the angle. It is 157. That means it is abnormal. And next I am putting the select series. You can see I selected the series, and I am going to, this is where the trochlear groove. So this is the TTG distance, TG. This I am calculating TG. And I am going down, and I am putting the where TT, tibial tubercle, it is TT. So I am putting that central line, and you can see now we can able to calculate it. It is the TTG distance. And how we can do it, you can see here. It is TTG distance. Simplified, you can see the measurements, it will come. It is simplified rule by doing confidently all these things done in single workstations. This is one. So the first lecture is gone. Madam, is it okay how I am taking? Is it okay? Huh? And 2 cases I will take it from there after completing all 3 lectures. There are 2 cases of patellofemoral instability. I will go there. After completing all these 3 things, I will come.